Dr. Ravikar Ralph is an associate professor in the Department of Medicine at CMC Vellore. He has a special interest in clinical toxicology and was instrumental in setting up the Poison Information Center at CMC Vellore, which has been a boon for physicians and hospitals all over the country dealing with patients with poisoning and envenomation. He will talk to us today about networking in medicine.
So the topic that I will be speaking on this evening is on the relevance of networking in the field of medicine. And I felt that this would be a good opportunity to share with all of you the experience that we have gained from the Poisons Information Center at CMC over the past 1 year. Now, Poison Information Centers, as I will be discussing in the subsequent slides, are a very good example of how networking can be used in healthcare to reach out and establish links with individuals, with groups, and with organizations that have common needs, that have common concerns, in order to collectively tackle a healthcare problem. My presentation is divided into 3 parts. The first part is an overview of what Poison Information Centers are. I will then be discussing very briefly the work that we have been involved in at our Poisons Information Center, mainly focusing on networking with healthcare providers. And I will also be speaking about and sharing some clinical case examples and some data that we have gathered over the last 1 year. So Poison Information Centers are specialized units that focus on providing poisoning related information to healthcare providers as well as the general public. While the information that is provided by information centers tends to vary from one center to the other, most centers help with information on diagnostic aspects of poisonings and envenomings. For instance, they help identify either a poisoning syndrome or a given chemical agent. They also help provide information about toxic dose, how long will it take for that toxin to be eliminated from the patient's body. They also help provide information about first aid as well as different aspects of management. They can help advise regarding appropriate decontamination strategies. They can also help with information concerning antidotes, the dosing and the side effects that can be associated with them. And they can also help provide some advice on methods that can enhance the elimination of the poison from the patient. In addition to these 2 activities, which are mainly provided to healthcare personnel, Poison Information Centers also help provide information regarding chemical safety and hazard identification to hospitals, industries, and they also engage with the community on awareness activities where they mainly focus on providing education on safe storage of medicines, pesticides, as well as prevention strategies for bites and stings. Now, most Poison Information Centers aim to contribute to a decline in the burden of poisoning and envenoming related morbidity and mortality in the region that they serve. And the WHO usually recommends that an ideal Poison Information Center is one that can serve a population of around 5 to 10 million residents who live around the center. Now, if we look at the number of poison information centers in addition to ours, which are there in India, we see that there is a marked paucity of centers. There are only 7 centers that are there in India, and as you can see, most of them are concentrated in just a few states. And therefore, the WHO's recommendation that a poisons information center needs to address or help 5 to 10 million residents is just not possible at this time, and many centers feel overwhelmed by the number of calls that they receive. Now, why was a Poisons Information Center started here at CMC? Now, we started a Poison Information Center here in response to a number of needs that have been recognized for several years. 60% of India's leather tanneries and associated tanning units, as well as wastewater treatment plants, are around CMC. And the lack of awareness amongst the industry workers, healthcare providers, as well as resident populations has resulted in issues concerning chemical safety, environmental hazards, as well as the use of personal protective equipment. Over the years, there have been a lot of studies that have shown that the indiscriminate disposal of hexavalent chromium that is used to tan leather into soil and water around industries has resulted in a lot of chronic health effects. Workers in these factories and tanneries develop painful ulcers because of chromium exposure called chrome ulcers, and there have also been very high rates of asthma as well as sinusitis in the resident population. In addition to this, there have also been a lot of acute fatal events that have occurred in these industries. For instance, there are a number of cases of hydrogen sulfide poisoning that have occurred at the wastewater treatment plants that are linked to these leather tanneries from where they receive a lot of organic waste. In fact, we have had at least one patient with hydrogen sulfide poisoning visiting CMC from these tanneries every year since 2016. So a watershed moment that occurred during our plans of starting a poison information center were the deaths of people at a common effluent treatment plant in Vanyambadi because of hydrogen sulfide poisoning. These were people who were working at the effluent treatment plant and were basically involved with wastewater management. These were deaths that were imminently preventable, and and as a result of this, we actually conducted a site visit where we noted that there were multiple lacunae at many different levels. The first important problem that we had noted were that none of these industrial workers were using personal protective equipment. In addition to this, there was no appropriate first aid that was available. And when we conducted a visit to the regional health facility where these patients with gas poisoning had been taken, we found that many of these doctors had been unaware of how to effectively diagnose as well as manage a toxic gas exposure. Now, this particular event led us to conduct an audit on referral pathways for patients with acute poisoning that were being admitted in Medicine 1. This was a one-year audit conducted between 2017 and 2018, where we found three important findings. One was that 97% of all patients with poisonings that were coming to CMC were coming from three surrounding districts of Vellore, Chittoor and Tiruvannamalai. And 88% of these patients had attended at least one primary or secondary care regional health facility before presenting to CMC. In most instances, these were patients who either sought discharge from the facility because they felt that they were worsening, or they clinically deteriorated and were referred by the healthcare providers for further treatment at CMC. Now, when we further examined factors that led to clinical deterioration at the referring center, we found that there were three important reasons. One was the delayed access to appropriate antidotal treatment. The second was patients receiving incorrect antidotes. And the third was an inadequate clinical stabilization before they were being referred. Now, even during transit, these patients continued to worsen, and so on arrival at CMC, they were either clinically unstable or they had developed complications which led to sequelae, and in some cases, the patients died shortly after they reached CMC emergency department. Now, these important observations led to us responding to these needs, and we felt that we could adequately respond by supporting healthcare providers and residents in these target districts by providing rapid information on first aid and antidotes, that we could ensure an early transfer of high-risk patients to tertiary care facilities, and also suggest basic treatment to stabilize these patients before they were being transferred. And it was to mainly facilitate these three objectives that the CMC Poisons Information Center was established and initiated in August last year. We are a 24-hour service. We are active 7 days a week throughout the year. We can be accessed many ways. We can be accessed via toll-free number. Queries can be sent to us via email. And if there are images that need to be shared, they can be sent through a WhatsApp number. Now, our activities can be divided into three categories. We are involved with networking with healthcare providers but there are also a number of community engagement initiatives that we are involved in, which mainly focus on the safe storage of pesticides and snakebite prevention and first aid care. And we also train healthcare providers in the management of common poisonings and envenomings. And in this presentation, I will mainly be focusing about our activities concerning our networking with healthcare providers. So this is the staffing and workflow pattern workflow pattern for when we network with healthcare providers. We are mainly staffed by a poisons information specialist, and we have physicians. The query is usually received by the on-call physician. Relevant clinical data is then collected and information is provided. We then usually initiate a review 4 to 6 hours after the first call, and we usually try to review the patient till at least 48 hours of their admission in the healthcare facility or till they are discharged. The information that we gather is then entered and stored into a poisons database by the poisons information specialist. Now, the most important source of information that we rely on is a poisons database called Toxbase that has information on about 17,000 different products and substances. It also helps with information concerning chemical incidents and provides monographs on teratology. We also use toxicology reference books in complex cases, and the cases and calls that we have been receiving have contributed to our own in-house clinical and products database, which we also use for similar poisonings. Now, this shows the number of calls that we have received over the last 1 year. We have received 1,453 calls between August and July of 2020. And as you can see, this is a month-wise breakdown of calls. Initially, the number of calls were few, but over a period of time, the number of calls gradually increased. The COVID pandemic, of course, was a challenge as far as the service was concerned, because there was a refocusing of priorities due to the pandemic, and the number of calls did go down, but we've again seen a resurgence in the call frequency since September 2020. Now, the other important and interesting finding is that despite the fact that our Poison Information Center was primarily established to cater to 3 districts around CMC, over the last 1 year, we've started receiving calls from many other parts of the country. This map actually shows the distribution of calls that we've been getting across India. And as you can see, the states that are shaded in pink are the states that we've been receiving calls from. And the intensity of the color actually corresponds to the frequency of the calls. Most of the calls have been from South India, but as you can see, we've also received a sizable number of calls from North and Northeast India. Now, 90% of all the calls that we receive are from healthcare providers, and only 10% are from the public. This is a table that shows the distribution of calls that we've received from hospitals according to tier of care. Now, as you can see on the first row, 60% of all hospitals that have called up are from the primary or the secondary level, and the calls that we get from these hospitals account for 52% of the total call volume. In contrast, 40% of all hospitals in our network are tertiary care centers, but again they contribute to a call frequency that is equally high, which is nearly 50%. Again, 60% of hospitals that call us are in the private sector, and they account for 60% of all the call volume that we receive. Now, these are the 5 most common exposure categories that prompt calls. Most of the calls that we receive are following agrochemical exposures. The other important categories are industrial and household chemicals, pharmaceutical overdoses, bites and stings, and plants and mushroom poisoning. Now, this is a breakdown under each category. Under agrochemicals, as you can see, most of the calls are for pyrethroids, herbicides, formamidines, and rodenticides. What's important is that only 11% of all agrochemical related calls are for organophosphate poisonings. And this could possibly be because of the fact that organophosphate poisonings are very well known. The cholinergic toxidrome is something that most physicians are familiar with, and that may possibly explain the smaller percentage. Amongst the category of industrial and household chemicals, the most common calls are for irritants, for hydrocarbon exposures, for minimally toxic household products like silica gel or nail polish removers. We also get calls for essential oil poisonings, especially camphor and eucalyptus oil, and 6% of all the calls are for corrosive injuries. Under the category of pharmaceutical overdose, the most common calls are for psychotropic agents and anti-epileptics. We also get calls for thyroxine overdose, paracetamols, and antihistamines. Under the category of bites and stings, most of the calls are for snake bites and scorpion stings, but we also have a large proportion where the bite is unknown. In a small number, we are able to make a clinical diagnosis of what the bite could possibly be, but then there are certain instances where we have to treat the patient based upon the symptoms. We also get a lot of calls regarding centipede bites and bee stings. Now, these are some of the common plant toxins that we have been able to help with from our center. The three most common plants that we get called about are Jatropha, which is the picture on the left. This is most commonly from Andhra Pradesh and Tamil Nadu, where Jatropha is very common. Most of the poisoning incidents occur in children who tend to eat the seeds of Jatropha as they play. The poisoning is very similar to castor poisoning. It's a cytotoxin and it usually presents with nausea, vomiting, and liver and renal failure. The second most common plant toxin that we get calls about is Dieffenbachia, which contains oxalate crystals in its leaves. And as you can see in this picture, again, children are usually exposed. They tend to tear bits of this leaf and eat it. This is actually a picture that we received at our poison center of a child who had eaten a piece of Dieffenbachia leaf. These oxalate crystals are insoluble, and so they tend to cause a lot of mucosal damage. So patients who ingest Dieffenbachia usually present with a swelling of the oral mucosa. They can come with laryngeal edema and with airway compromise. The third important plant that we usually get calls about is Anamerta cocculus. These calls are mostly from Kerala, where this plant is a rampant weed. The seeds of Anamerta contain the well-known toxin, which is called picrotoxin, which blocks the GABA channel and causes severe seizures, recurrent seizures. So this is another important plant toxin that we help with. Now, this pie chart actually shows the distribution of calls by the age of the victim. Nearly 50% of our calls are concerning exposures in adults, and the other 50%, 48% are from poisonings and envenomings in children. This is a graph that distributes accidental and intentional poisonings between children and adults. As you can see, the majority of incidents amongst children are because of accidental exposures. That's the yellow bar graph, 93%. In contrast to this, the majority of calls that we receive concerning poisoning in adults are because of intentional self-harm. A very small number are because of accidental poisoning exposures. Now, this is our follow-up data. We have been challenged as far as following up patients is concerned, and we have a very small subset of patients who we actually have been able to follow up till 48 hours of admission. It's 296 patients, and as you can see, of these, 62% of patients were cured and discharged within 48 hours. They had a very short hospital stay. 3% of patients expired. 8% were referred to another hospital, 9% sought discharge against medical advice, and 18% continued to be hospitalized for their illness beyond 48 hours. Now, in the next few slides, I'm going to share some clinical case examples that would help highlight the many different ways we can actually help with each of these calls that we get. And the first case that highlights these different aspects of our engagement with healthcare providers is that of a 35-year-old farmer from Tamil Nadu who intentionally ingested an agrochemical agent. This is the picture that you see on the right is the picture that was sent to our center. As you can see, there was very little information on the label regarding the product that he had ingested. The only thing that we could get was that it was a vegetative derived organic product and that it enhanced plant growth. 30 minutes after he had ingested this agrochemical agent, he developed nausea, vomiting, and abdominal pain. He presented to a secondary center 2 hours after ingestion, and the physician in the emergency department noted that the patient had tachycardia, he had respiratory distress, and that he was hypoxic. The physician presumed that the patient had ingested an OP poison because he felt that this was something that was very common in Tamil Nadu. He proceeded to treat the patient with atropine. The patient received a total of 3 milligrams of atropine. He continued to have worsening respiratory distress. His hypoxia worsened, and he ended up getting intubated. It is at this point in time that the physician called us, and the question that he had for us was whether this patient should receive pralidoxime. Now, as a first step, we ensured that the patient was hemodynamically stable, that his ventilatory parameters were stable. We then proceeded to guide the physician in reviewing the history and physical findings in the patient. And we found that there were two important clinical facts that had been missed when the patient had first presented to the hospital. The first important fact was that this patient at no point in time had any features of a cholinergic toxidrome, especially meiosis and diaphoresis had not been present both at presentation and even after he had been admitted in the emergency department of the center. The second important finding that the physician was able to tell us about was that the patient had developed central cyanosis, but he had clear lung fields and he had a normal jugular venous pressure, and he did not have any features that were suggestive of cardiorespiratory failure. So the clinical diagnosis that we made at this point was that of methemoglobinemia. Unfortunately, there was an arterial blood gas analysis was not available in the hospital because the patient was severely cyanosed. We suggested that he receive methylene blue therapy, and we also requested that the physician send us a photograph of a patient's blood sample. Now, this is the picture that was sent to us via WhatsApp. The blood drops on the left on the gauze piece are from the patient, and those from the right are from the control. You can see that the patient's blood had acquired a chocolate brown color, which is very strongly suggestive of methemoglobinemia. This is a color that usually tends to occur when methemoglobin percentage is more than 15%. And when we correlated this fact with the patient's finding of severe cyanosis and respiratory distress, we were able to assess that the patient would have had anywhere between 45 to 70% methemoglobin levels in his blood. The physician proceeded to treat the patient with methylene blue. There was a normalization of oxygen saturation 2 hours after the antidote was given. The patient rapidly improved and he was extubated the next day. Now, some of the important learning points that we would like to highlight from this case is that a toxidrome recognition is very, very important in managing poisonings, especially in India. That is because the identity of the toxic product is rarely available on container labels, and so it is very difficult to provide information just by looking at a poisons database. And this problem becomes even more complex when the poison is not an organophosphate poison and the toxidrome that the patient is manifesting is an unusual one. And it is in this context that I would like to highlight the role of a physician in a poisons information service. Most of the other centers in India right now are staffed by pharmacologists, pharmacists, and forensic medicine experts. But as I have shown from this example, a physician would also strongly contribute towards making a clinical diagnosis and initiating early appropriate therapy. The second important learning point is how simple bedside tests can actually address technological lacunae in the peripheral hospitals. For example, the gauze test that I showed, which is derived from a color qualitative test that Sri Lanka had published in the WHO. Now, the second case that also highlights this example of how a poison information center can help is that of a 32-year-old army Jawan who was posted in Tuensang in Nagaland. Now, he had a snake bite on the right ankle one evening when he was returning back to his camp from the roll call. This is the photograph that was sent to us. You can see that he has had a bite on the right foot and his foot has swollen. In addition to the local swelling, he was also found to have incoagulable blood, but he did not have any overt bleeding or muscle weakness. The snake had been killed and brought to the camp hospital. The physician identified this as Russell's viper and he proceeded to treat the patient with 10 vials of Indian antivenom. He waited for 6 hours and repeated the blood clotting tests and found that the blood continued to be incoagulable. This patient then went on to receive 58 vials of Indian antivenom over the next 72 hours. His blood continued to be incoagulable and the limb swelling started worsening and extended up to his groin. It is at this point that we received a call at the poison center and the physician wanted to know as to how to proceed further and whether the patient requires further antivenom dose. Now, there were two important facts that helped us in this case. The first and the most important fact was the location of the bite. Usually Russell viper bites are not very common in Northeast India as well as in Nepal and Bangladesh. And the second was the altitude of the location. Tuan Sang especially is a high altitude location. And it's a very mountainous area. And therefore, we requested that we would like to review the photograph of the snake. Again, like in the previous case, we ensured that the patient was stable clinically. We also had a detailed review of the history and physical findings, and we reviewed the photographs of the snake. Now, this is the photograph that was sent to us from the center, and what we found was that the snake that had bitten this patient was actually not the Russell's viper, but the mountain pit viper, Ovophis monticola. And as you can see from an enlarged photograph of the snake's head on the right, this snake, unlike the Russell's viper, has the pit organ, which is a heat-sensing organ between the eye and the nostril. And this is a fact that can very rapidly tell us that this is unlikely to be a Russell's viper. Now, a very important fact associated with this identification is that the venom of Ovophis monticola is not neutralized by Indian antivenom. And so what had been happening is that the patient was being exposed to antivenom unnecessarily and being exposed to the risk of developing severe anaphylaxis. So what we suggested was that the physician stop administering further antivenom. Because the patient did not have clinically overt bleeding, we suggested that he be carefully examined every day for progressing envenoming. We also from our side reviewed him every day through daily follow-up calls, and we suggested that blood coagulation tests be done thrice a week. This patient's limb swelling eventually improved and then resolved on day 12. He took nearly a month for his blood coagulation to normalize, and he was subsequently discharged without any further sequelae. Now, the learning points that we would like to highlight from this case is that it is very important to identify the biting species before antivenom treatment. This is especially important because currently the concept of the big four is redundant. It was a common understanding that there are 4 major species of snakes in India that are responsible for medically important bites, namely Russell's viper, saw-scaled viper, the Indian cobra, and common krait. But over the last 10 years, there are a number of different locally prevalent snake species that have been described and discovered, and this fact is very important because the venoms of these species are not neutralized by Indian antivenom. The other important fact is that local snakes, scorpions, poisoning plants are very unique to regions, and so this information again cannot be easily accessed and provided by a poisons database which is based upon Western data. Another important point that I'd like to highlight is that an early consultation with poisons information centers or with physicians who have experience in treating envenoming is very important, because it helps, like I've shown through this case, it helps treat envenoming by lesser known but regionally prevalent species. It also prevents a misidentification of the cause of bites. There have been many instances where we've received calls for scorpion stings that were misdiagnosed as snake bites and treated with antivenom. And it also allows for early discharge for patients bitten by non-venomous snake. This is a particular problem that we found in our calls. Nearly 42% of all calls that we get are bites due to non-venomous snakes where patients have been treated with antivenom and in many instances have developed antivenom related complications. These are 2 common mimics that we get calls regarding. The first one, the picture on the right, is a non-venomous snake called the sand boa, Gongylophis conicus, which is very often mistaken for Russell's viper. The snake is often killed unnecessarily and patients are administered antivenom. The second common mimic is the picture on the right, the Indian wolf snake, Lycodon aulicus, which is often mistaken to be the common krait. So in summary, the points that I'd like to highlight are that poison information centers can play a very important role in supporting healthcare providers in diagnosis and management of poisonings and envenomings. It is very, very important that poison information centers in India have a firm grounding in clinical medicine because of the unique challenges in the region, and that there is a pressing need to provide healthcare workers, especially in primary and secondary facilities, with training in the management of common poisonings, bites and stings. And networking would really play an important role here because it would identify stakeholders that can participate in such initiatives. Thank you, and I will leave you with the contact details of our center, which can be accessed at any time during the day. Thank you.